Welcome, healthcare providers. Today we're focusing on a pediatric condition that really tests our diagnostic skills, Kawasaki disease. Our aim here is simple. Get you the key insights fast.
Exactly. We want to clarify how it presents and how it's managed, because recognizing it early is absolutely vital for these kids.
Okay, let's start right there. What is Kawasaki disease, fundamentally?
Well, it's a rare childhood illness,
Ah,
an acute one. It causes inflammation, pretty widespread, in the walls of small and medium-sized blood vessels, all through the body.
and the significance? Why the urgency?
It's because it particularly likes to target the coronary arteries, the vessels supplying the heart muscle itself. That inflammation can really compromise them.
Right, directly affecting the heart supply. That certainly flags it as serious. So who are we primarily seeing this in? What's the patient profile?
Mostly children under 5 years old.
Under 5.
Yeah, the highest risk group seems to be between 6 months and 5 years. We also see it slightly more in boys and definitely more in children of Asian or Pacific Islander descent.
Interesting demographics. Is there any seasonality to it?
There is, yes. It tends to pop up more often in the winter and early spring months.
Okay, useful to know. But in a busy clinic, what are the absolute core symptoms we need to have on our radar?
The number one thing is a high fever. We're talking over 39 degrees Celsius, and importantly, lasting at least 5 days. That duration is key.
5 days or more. Got it. What else makes up the classic picture?
You're looking for a constellation of signs. A rash, often quite varied, red eyes, but typically without any pus or discharge. That's bilateral conjunctivitis.
Okay.
Then changes in the mouth, think red, cracked lips, maybe a very red swollen tongue, sometimes called a strawberry tongue.
Strawberry tongue, right.
Also swollen lymph nodes, usually just one, quite large in the neck. And finally, changes in the hands and feet, swelling or redness, sometimes followed by skin peeling, especially around the fingers and toes, maybe a week or two later.
So it's really that cluster of symptoms together with the persistent fever.
Exactly. One symptom alone isn't specific, but the combination is highly suggestive.
Are there other symptoms that might show up? Things that could, muddy the waters diagnostically?
Oh, absolutely. Some kids present with significant belly pain, maybe diarrhea or vomiting. Irritability is common, especially in younger infants. Joint pain can also occur.
I can see how that could easily point towards other common illnesses first.
It really can. That's why keeping Kawasaki disease in the differential is so important when that fever just won't quit.
And what about this incomplete Kawasaki disease? It sounds even more challenging.
It is. This is when a child has that defining high fever for 5 days or more, but they have, say, only 2 or 3 of the other main symptoms, not the full 4+.
So fewer classic signs.
Right. But here's the critical part. These children are still at risk for the same serious heart complications.
Even without the full picture.
Precisely. So you need a really high index of suspicion, maybe rely more on lab markers or echocardiogram findings, if the clinical picture isn't complete but the fever pattern fits.
That leads us right to the complications. What is the major serious outcome we're trying to head off with early diagnosis and treatment?
The absolute primary concern is damage to those coronary arteries. The inflammation can weaken the artery walls,
Leading to
aneurysms. These are like dangerous bulges or outpouchings in the artery wall. They can increase the risk of blood clots forming, potentially causing a heart attack, or though rarely, they can rupture. It's serious business.
Definitely sounds it. Detecting those aneurysms must be key.
It is. Echocardiograms are essential for monitoring the coronary arteries, both initially and over time.
Given these high stakes, especially cardiac ones, how quickly does treatment need to start? What's the window?
Treatment really needs to begin within 10 days of the fever starting.
10 days? That feels like a tight time frame.
It is. Starting treatment, usually with intravenous immunoglobulin, within that 10-day window, dramatically reduces the chances of developing those coronary artery aneurysms.
Okay, so prompt treatment is protective. Now, what about the cause? Do we know what triggers it? And is it something parents need to worry about spreading?
Frustratingly, the exact cause is still unknown. The leading thought is it's likely an abnormal immune response triggered by an infection, maybe combined with environmental factors or genetic predisposition in some children.
But not contagious.
Correct. It does not spread from person to person. So no isolation needed beyond standard precautions for fever. And currently, there are no known ways to prevent it.
All right, so if we do catch it early within that 10-day window and start treatment, what's the usual outcome?
The prognosis is generally excellent with timely treatment. Most children recover fully. The fever comes down, symptoms resolve, usually within about 2 months, and they typically have no long-term problems.
That's really reassuring. It all seems to hinge on catching it early. So let's boil it down for everyone listening. When should a child absolutely get an urgent evaluation, specifically looking for Kawasaki disease? What's the trigger point?
The main red flag is any child with a persistent high fever, remember, over 39 Celsius for more than 3 days. If that fever hits day 4 or 5, especially if any other potential Kawasaki symptoms are present, even just 1 or 2.
Don't wait for the full textbook picture.
Exactly. Don't wait. Prompt evaluation by a healthcare provider is essential. Think Kawasaki disease early.
That's such practical advice. This knowledge really matters in your day-to-day practice. Being vigilant can truly alter a child's outcome.
Absolutely. Your assessment can prevent serious heart issues down the line.